as all of you know, that how do we manage the metastatic prostate cancer? The best way is the androgen deprivation therapy. And this androgen deprivation therapy is achieved either by bilateral orchidectomy or by giving the various agonist and antagonist for the LHRH. So one can really see that these are the standard treatment for hormone sensitive prostate cancer. And that has been going on for a long time, that all of us are using the either bilateral orchidectomy or the use of the androgen deprivation therapy in the form of the injections, which reduces stop the production of testosterone. This has been the major sort of a treatment for long, and then some of all these patients ultimately develop the hormone resistant prostate cancer. And that's a time we have got large number of drugs which are used, whether it is a docetaxel, whether it's abiraterone, enzalutamide, then cabazitaxel, mitoxantrone, and so on and so forth. All this, the hormone resistant prostate cancer is because of the multiple mutations in various genes which ultimately lead to the resistance. And that's where all these drugs are very useful. However, the most important part remains that when you start the treatment in the hormone sensitive prostate cancer, I think the important thing is to keep the prolongation of the hormone sensitivity for a long period of time. And that's where a patient will have a good quality of life. And there have been a lot of effort in that direction. One of the ways to add the docetaxel upfront along with the androgen deprivation therapy. And that was shown to be useful and superior to the alone androgen deprivation therapy. Then came the combination of ADT with the abiraterone. And that also showed that addition of abiraterone makes the difference. And today, what we are going to see in the trial is that how enzalutamide also when added to the ADT that can be better. So the background is that enzalutamide, which is a potent androgen receptor inhibitor, has been found to be useful in the hormone-resistant prostate cancer. That is well established. Many of these patients will respond for a variable period of time. Also, in the various trials, it has been shown that there's a long-term suppression of the PSA after the use of enzalutamide. And that's where now we have got now hypothesis that enzalutamide in combination with ADT will show affect the progression-free survival. Next slide. Next slide. So the ARCHES trial randomized the patient to alone ADT with placebo versus the ADT with enzalutamide. So it was 1-to-1 randomization where enzalutamide was used in 160 milligram daily. Next slide. And I think next slide. If you look at all the criteria, you can see they were equally distributed, whether it's with respect to the ECOG performance score or Gleason score or localization of the metastasis and the prior therapy. Everything was absolutely equal in both the groups. Next slide. And look at the results. That radiographic progression-free survival was definitely superior to the patients who received the enzalutamide along with the ADT. So I think this has now established that how we can improve the progression-free survival in the patients who has hormone-sensitive prostate cancer. Next slide. Not only that, next slide. If you look at all the criteria, we can see that this advantage is seen irrespective of the various subgroup. So in subgroup analysis, the benefit is seen in almost every type of the patient. Next slide. Also, the PSA progression, which was the secondary endpoint, was delayed in patients with who received the enzalutamide. Next slide. And thus suggesting that it is very clear that addition of the enzalutamide makes a big difference. Particularly, you can see how the overall response rate is definitely superior, 83% versus 63%. Next slide. And all this thing was achieved with very little of additional side effects. Next slide. In terms of adverse effect of special interest for the hypertension and some of the other fatigue, sometimes diarrhea, but they are all manageable with a very little really additional problem. Next slide. So what this trial show really that addition of enzalutamide to the ADT makes a big difference in managing the patient with hormone-sensitive prostate cancer. And also, maybe we may come up with the overall survival, which may be higher in such a group. Next slide. And thus, conclusion is very clear that enzalutamide with ADT significantly reduced the risk of metastatic progression over time versus a placebo and ADT. It is well tolerated, and in both the group, the quality of life was maintained over a period of time, and enzalutamide plus ADT should be considered as a treatment option with hormone-sensitive prostate cancer. So friends, what we have discussed is that in contrast to the condition like using the ADT along with the docetaxel or along with the abiraterone, this enzalutamide seems to be superior in terms of the acceptance as well as in terms of maintaining the quality of life. Thank you very much.